Introduction. Select to favorite. Altered mental status in children is characterized by the failure to respond to verbal or physical stimulation in a manner appropriate to the child's developmental level. The ED incidence of altered mental status in children varies widely depending on the type of institution reporting, the patient population served, and the specific definition of altered mental status used. Children with altered mental status require simultaneous stabilization, diagnosis, and treatment. The objectives of treatment are to sustain life and prevent irreversible CNS damage. Once the patient is resuscitated, the goal is to determine the cause. Arousal is mediated by the neural pathways of the ascending reticular activating system that project from the brainstem to the hypothalamus, thalamus, and cerebral cortices. The ascending reticular activating system regulates wakefulness in response to the environment, as well as homeostasis, cardiovascular, and respiratory functions. Altered mental status occurs through dysfunction of the ascending reticular activating system, an insult to bilateral cerebral cortices, or global depression of the central nervous system. There are many factors that can cause dysfunction in the ascending reticular activating system and cerebral hemispheres, including inadequate substrate for metabolic demand, insufficient blood flow, presence of toxins or metabolic waste products, or alterations of body temperature. Typical causes of bilateral cortical impairment are toxic and metabolic states that deprive the brain of normal substrates. There are multiple pathologic conditions that affect awareness and arousal. Etiologies can initially be described as traumatic or non-traumatic. Non-traumatic causes can be further divided into structural and functional lesions. Structural lesions can be categorized as supratentorial or subtentorial. Signs and symptoms of supratentorial lesions include focal motor abnormalities, which are often present from the onset of the altered level of consciousness. Subtentorial lesions lead to reticular activating system dysfunction, in which prompt loss of consciousness is common. Cranial nerve abnormalities are frequent, and abnormal respiratory patterns are seen. Functional etiologies include infectious, inflammatory, metabolic, nutritional, toxic, and neurologic psychiatric disorders. Depressed consciousness is typically seen before motor signs become depressed, and when present, motor deficits are typically symmetric. The spectrum of alteration of mental status ranges from confusion or delirium, disorders in perception, to lethargy, stupor, and coma, states of decreased awareness. A lethargic child has decreased awareness of self and the environment. Patients may be aroused from an apparent deep sleep, but they immediately rapidly assess and support the airway, ventilation, and circulation. When the patient is stabilized, take a methodical and comprehensive history, Table 140-1. Ask about the prodromal events before the change in consciousness as well as recent illnesses or infectious exposures, and determine the likelihood of trauma, abuse, or ingestion. Inquire about antecedent fever, headache, head tilt, abdominal pain, vomiting, diarrhea, gait disturbance, seizures, drug ingestion, palpitations, weakness, hematuria, weight loss, and rash. For infants and young children, review developmental milestones. The medical, immunization, and family histories are important in children of all ages. Be alert for any inappropriate responses, inconsistencies, or delays in seeking care that may arouse suspicion for child abuse. See Chapter 150, Child Abuse and Neglect. Proceed with a general examination only after respiratory, cardiac, and cerebral stabilization. The objectives of the examination are to identify occult infection, trauma, toxicity, or metabolic disease. The neurologic examination should document the child's response to sensory input, motor activity, pupillary reactivity, oculovestibular reflexes, and respiratory pattern. Although several coma scales have been published, such as the Modified Pediatric Glasgow Coma Scale, see Chapter 110, Pediatric Trauma, and Chapter 111, Minor Head Injury and Concussion in Children, the most simplified and functional scale in an emergency setting is the AVPU scale, Table 140-2. The Glasgow Coma Scale lacks good inter-observer reliability and reproducibility and does not accurately predict outcomes in individual patients. The AVPU score has been validated and is currently recommended by the Pediatric Advanced Life Support Guidelines. The A, V, P, and U values correspond to Glasgow Coma Scale scores of 15, 13, 8, and 3, respectively. Once the child is stabilized, the history and physical should suggest either a medical disorder or structural lesion. The mnemonic karyotypes, alcohol, encephalopathy, insulin, opiates, uremia, trauma, infection, poisoning, and seizure, is a useful tool for organizing the diagnostic possibilities of altered mental status in children. Table 140-3. If a metabolic cause is suspected, obtain serum electrolyte levels, renal and hepatic function studies, serum ammonia, CBC, and coagulation studies. See Chapter 146, Metabolic Emergencies in Infants and Children. If the history or examination suggests a toxic ingestion, obtain serum levels of suspected agents and a urine toxicology screen. Consider trial of an antidote, if available. Obtain arterial blood gas analysis, CBC, and pulse oximetry in cases of trauma, respiratory distress, or suspected acid-base imbalance. Obtain a 12-lead ECG and provide continuous cardiac monitoring if there are pathologic auscultatory findings, rhythm disturbance, or suspected toxin exposure. For serious bacterial infection, obtain blood and urine cultures. Correct shock, hypotension, and hypoxia before attempting lumbar puncture. See Chapter 119, Fever and Serious Bacterial Illness in Infants and Children. The clinical scenario directs imaging. Immobilize the cervical spine and radiograph the cervical spine if spine injury is suspected or in the case of multiple system trauma. If an intracranial lesion is suspected or if there are focal neurologic signs, obtain a non-contrast CT scan of the head. If vascular injury is a possibility, consider CT angiography of the head and or neck. A chest radiograph confirms or clarifies examination findings and documents endotracheal tube placement. Abdominal radiographs are indicated to assess for acute ingestion of radiopaque material. Abdominal US may be useful to screen for cases of intussusception. See Chapter 133, Acute Abdominal Pain in Infants and Children. Other studies that may be useful in specific cases are serum osmolality, blood alcohol level, thyroid function test, blood lead level, and skeletal survey for suspected abuse. Electroencephalogram will evaluate for nonconvulsive status epilepticus. Treatment principles are outlined in Table 140-4. Begin with airway, breathing, and circulation, and administer 100% oxygen until adequate oxygenation is confirmed. For suspected increased intracranial pressure, elevate the head of the bed to 30 degrees. Establish N4 and give normal saline to restore and/or maintain perfusion. Obtain a stat point of care glucose and treat hypoglycemia. If the history or the exam suggests opiate toxicity, give naloxone. For suspected meningitis, give antibiotics and/or acyclovir. Once the patient is stabilized, the child should be observed until his or her mental status improves. The patient's clinical condition and specific disorder dictate whether further management can occur on the inpatient unit or in an intensive care unit. Only patients with transient, reversible causes may be treated, monitored in the ED, and discharged after observation and a return to their baseline mental status. Patients who are discharged, for example, those with a closed head injury or simple febrile seizure, should receive disease-specific discharge instructions. Children who are evaluated for altered mental status and discharged home should have a repeat evaluation within 24 hours of discharge.